And then how do we evaluate the data that we captured? We also don't have a few authors that are there on the study with us right now here. We participated with Dr. Jos, Dr. Tebul from UK and France respectively, Dr. Lopa from Bangladesh, and also a few participants from our team as well, which unfortunately cannot be here today. So a big thank you to them as well. I would request Dr. Ambuj and Dr. Himanshu and Dr. Mishra with me to unveil the study. Find very few, like for example, less than 100 patients and things like that. These 700 patients were there for 5 days on average. That is why the context of 85,000 hours of data that was captured is very important when it comes to this. And yes, before we extrapolate the results to the larger country, we need to keep adding more studies to this, right? So at Dozee, for example, we followed it up, so we are now following clinical publications and clinical studies that are coming up, which adds close to almost 5,000 more to this number, and we're showing similar results on those as well. So yes, it's a continuous endeavor, and I think we should get to as many patients as we can in terms of a sample size to be able to extrapolate it, but yes.
So you have lots of studies but very small studies. Now, if I look at it in a scientific way to say whether the sample size is statistically important or not, you need to have the number of events. From that you would calculate. But if you look at all the studies, they do not actually point out. So this was a point which we took in our when we went for our ethical clearances and all. So this study is the first. When you do not have such data, what you do a pilot study initially to see what is the number of events, what are the number of such events that you would see with the number of sensors that you have. So this was the first stage pilot study, and as Gaurav has pointed out, we are going for a much larger study. It's not that we are going to end up with just this. The number of events that we saw, now we'll calculate and have a proper full sample size. But even for a pilot study, it has a pretty good number. That is, and a pretty good number of events which were recorded. That is what is it.
One thing is applied. In medical field, it starts like we get first case report or some 1, 2, 3 case report we observe, and then we go for pilot study. When we go for pilot study, we look for that it is the intervention, it is observation. So it was not intervention, we were not giving any treatment, we were just monitoring what happens in routine, that we have a background data. Before device, how many patients used to get sick and go to ICU, that data we had. And when we applied this device, how many patients could be saved in that particular time in going to ICU, event were noticed, which were missed. So it was like observation. So when you do observation study, we are just giving that if a traditional monitoring has been done, that they should have delayed. So since no intervention, no treatment is done, so the question of bias doesn't come. Question of exclusion or inclusion doesn't come. We have just exclusion because pediatrics we were not monitoring. This study was for adult. So when you do observation study, we are putting this device and we are looking for sensitivity and specificity. There is a well-defined mathematical models to do a pilot study and do the calculation that how many events are happening in that particular hour. So if you take one patient, then one patient becomes 1,000 because we are looking for the hours. Some patient can stay for 24 hours, some patient can stay for 5 days. So we are looking for 24 hours. In 24 hours, how many events are happening which can take your patient to ICU, which can take your patient to death, or which get unnoticed. So this was the thing. That's the reason you need to not only look for the number of patients, you need to look for the number of hours this device was applied. And in number of hours, what it did, it said this many hours for the staff work, it said this many events, it alerted early.
Dozee is a contactless, continuous remote health monitoring solution that has sensors that go under the mattress. They don't even touch the patient and can get heart rate, respiratory rate and non-contact blood pressure with very high compliance when the patient is on the bed. Additionally, it can monitor more vitals like SpO2 and temperature from other accessories wireless. What the enablement of all of these vitals do is it enables us to create a AI-powered early warning system where we can identify signs of health deterioration in patients and alert the healthcare professionals, doctors, nurses in time so that they can take action. At King George Medical University in Lucknow, almost 1.5 years back, we started this clinical study where under an observational study, we did not change any clinical protocol of the hospital, but we collected data on 706 patients, close to for 85,000 hours of data. That itself is a big feat, collecting this much amount of vitals for patients in a tertiary healthcare setting, which is very, very busy, almost 90% occupied, and in a nurse to patient ratio of 1:36. In that, collecting these vitals in itself shows how, with very great compliance, Dozee can collect these vitals for almost 20 hours a day per patient without even bothering them. On top of this, we also showed that we can capture 94% of patients that required critical care, that required emergency critical care in these wards, in the internal medicine wards, up to 16 hours in advance. And while doing all of that, we have the potential to save 10% nursing time. The time that is spent in manual documentation, spot check, vital collects, and actually communicating them as well. Because all of this is collected on a minute by minute, digitally stored, and is available for healthcare professionals to look at in real time live, but also to look at later as well while they are reviewing their protocols or where they are looking at the trend of the vitals of a particular patient. So this greatly helps them in delivering better care to patients in the wards outside the ICU. It also helps in reducing costs as well by obviously saving time, but also reducing costs because these patients, less patients will end up in an ICU in emergency. So saving ICU costs, which is the most important critical resource of the country. Also the patients that have been identified in time will actually spend lesser time in ICU and will require lesser critical care to actually recover and go back home.